Welcome to the deep dive. Today, we are taking on a colossal yet immensely high-yield territory. Pediatric neurology, cognitive health, and developmental alterations.
It's a huge field.
It is. It's dense, it's packed with critical decision points, but we have organized all your essential materials, the core lecture content, your key point notes, and those critical clinical reasoning concepts
Yeah,
into a structured learning session that's really designed for absolute mastery.
that's right. Our mission is built around efficiency and, clarity. We're trying to transform this raw volume of information into actionable clinical knowledge.
Okay?
So we've clustered the material into 5 logical, high-impact sections. We've grouped them by similar pathophysiology and urgent management patterns.
Let's lay out that map for everyone.
Yeah.
So cluster 1 is focused on the most acute situations.
Yeah.
Acute intracranial pressure and trauma.
The really scary stuff.
Exactly. Then cluster 2 shifts to immediate crisis management, seizure disorders, and status epilepticus. Third, we tackle CNS infections and autoimmune neuropathies, sort of recognizing that inflammatory response.
Right.
Our fourth segment covers structural and chronic neurodevelopmental defects, like spina bifida and cerebral palsy. And finally, cluster 5, which addresses cognitive, genetic, and mental health alterations, including things like ID, ASD, and ADHD.
And for every single topic within those clusters, we'll apply 5 critical learning pillars. This is basically your checklist for clinical practice and, high-stakes testing.
Okay, what are they?
We will detail the mechanism or pathophysiology, the essential why. Then we'll identify hallmark symptoms, and we'll really differentiate between infants and older children.
Crucial difference.
It is. Then we cover pharmacological and non-pharmacological management. We pinpoint priority nursing actions, your ABCs, and safety. And finally, we isolate the red flags and those crucial clinical traps to protect you from common distractors.
Perfect. That structure is really designed to make complex information stick.
Okay.
Let's unpack this, starting immediately with cluster 1. The highest acuity situations, acute intracranial pressure and trauma. Okay, so our first cluster, we're calling this one ICP and acute neurotrauma.
Right.
And the unifying idea here, I think, is that pediatric anatomy makes these patients uniquely vulnerable. They are not simply small adult.
Not at all. Their structural makeup places them at a significantly higher risk for rapid neurological decline following an injury. That is the absolute foundation here.
So what's the mechanism behind that vulnerability?
It really stems from 2 primary differences. First, a child's cranial bones, they aren't completely ossified. That means their sutures and their fontanelles are still open.
Which allows for brain growth, right?
It does. It allows for that rapid brain growth, yes, but it also creates a much less stable structure during any kind of traumatic event.
Okay, that makes sense. And the second difference?
Second, and this is crucial, is that the child's brain has a much higher water content than an adult's.
And why does that increased water content matter so much?
Well, think of it like this. A brain with high water content is just more susceptible to shearing forces. So when an acceleration-deceleration injury happens...
And a fall or what we see in abusive head trauma?
Exactly, formerly known as shaken baby syndrome. With that high water content, the brain tissue moves and shears more easily against the ridges inside the skull.
Oh, wow.
And that causes diffuse axonal injury and really significant swelling. This is why brain injuries are the most common cause of traumatic death in children under 2. The biomechanics are just. They're working against them.
So that structural vulnerability means that recognizing increased ICP is like a moment-to-moment critical skill.
It is.
And the manifestations, as you said, are profoundly different in infants versus older children.
Absolutely. In infants, so we're talking children with open fontanelles, the clinical picture is unique. The skull can still expand slightly, which might mask the pressure for a short time, but it leads to very specific visual cues.
Okay, so what are we looking for at the bedside?
You're looking for irritability and restlessness, a tense or even bulging fontanelle that you can see when the child is upright and quiet. You'll see distended scalp veins and sutures that might look wider than they should.
And head circumference, I assume.
Meticulously. We track head circumference meticulously. An acute increase is a massive red flag. And then there's that unmistakable sign, the classic high-pitched, often piercing cry. Some people describe it as sounding like they got stepped on.
Right. And then what about in an older child once those sutures have fused?
So in the older child, the symptoms align more with what we expect in adults. The skull is now a closed box, so the pressure causes headache, nausea, and notably forceful vomiting that's often completely unrelated to food.
Just projectile vomiting.
Exactly. They might report blurred vision, what we call diplopia, experience new onset seizures, and show marked cognitive shifts like lethargy or just difficulty following simple commands.
So the clinical shift we're always monitoring for is that progression to the late signs of ICP.
Yes. And the single most crucial indicator, doesn't matter what age, is always a change in the level of consciousness, your LOC.
Always the first thing to change.
A subtle change in alertness or orientation will happen long before the vital signs change.
And when those vital signs do change, it's catastrophic. We're talking about the Cushing triad.
We are.
Let's really explain the physiology here, not just list the signs, because knowing the why helps it stick.
That's a great point. So this is a classic but failing compensatory mechanism. When the ICP rises to a dangerously high level, it starts to compromise the brainstem's blood supply.
Okay.
The body's immediate, almost frantic response is to try to perfuse that brainstem. It does this by drastically increasing the mean arterial pressure, the MAP, to try to overcome that high ICP.
So it's cranking up the blood pressure.
Right.
Yeah.
And this massive vasoconstriction results in a very high systolic blood pressure and a relatively lower diastolic BP. And that creates that dangerously widened pulse pressure.
So the increased BP is actually the body trying to save itself.
It is, exactly. But this high systemic blood pressure triggers a reflex response from the vagus nerve. It's a baroreceptor reflex, which causes the heart to slow down dramatically.
Which leads to the bradycardia.
The bradycardia. You couple this with direct brainstem compression affecting the respiratory center, which causes irregular respirations, and there you have it, the complete deadly triad.
So you see an HR of 48, a BP of 150/70, irregular breathing.
That demands immediate intervention.
The pupils provide another essential window. How do we interpret those changes?
You're assessing two things: reactivity and size. A unilateral, dilated, but still reactive pupil often suggests a localized mass effect, maybe a hematoma.
Okay.
The most alarming sign is a unilateral fixed and dilated pupil that suggests impending brainstem herniation. The oculomotor nerve, cranial nerve 3, is being compressed.
And if it progresses beyond that?
If you see bilateral fixed and dilated pupils, that indicates irreversible severe brainstem damage, likely complete herniation or brain death.
Okay, let's talk clinical reasoning and avoiding pitfalls. So priority assessment. You walk into a room, the primary cue is that LOC change.
Yes. You assess this before you check vital signs, before you look for focal weakness. It is the earliest sign of neurological deterioration.
And we just detailed why the Cushing triad is such a huge red flag. If you see those vital signs, clustered low heart rate, wide pulse pressure, irregular breathing,
You skip the rest of the assessment and you call for immediate support. You activate a rapid response.
in terms of intervention safety, avoiding anything that acutely raises ICP is critical. This is a super common trap quotient.
It is. You must question orders for, say, passive range of motion that involves hip flexion or anything that causes unnecessary pain or stimulation. That all triggers a Valsalva response or a hypertensive response that just spikes the ICP.
So positioning has to be gentle and deliberate.
Absolutely.
We also look for specific red flags post-trauma that might suggest a basal or skull fracture.
Right. So if you see clear nasal discharge that tests positive for glucose, that means you are looking at cerebrospinal fluid, KSF,
A direct line for infection.
a direct line from the environment to the meninges. And then there's the classic visual signs: periorbital ecchymosis, the raccoon eyes or battle sign, which is bruising behind the ear, all classic for a basal or skull fracture.
And what about submersion injuries or drowning?
Even a brief submersion, even in just 2 inches of water, can cause a hypoxic ischemic brain injury. These kids must be immediately resuscitated, and critically, they have to be admitted for 24 to 72 hours of observation.
Why so long?
Because the adverse effects, things like cerebral edema or aspiration pneumonia, can take time to manifest. You can never assume a brief submersion means they're okay.
Got it. Okay, let's move to farm and non-farm management. So when ICP is high from cerebral edema, what's our go-to?
The primary pharmacologic intervention is mannitol. It's an osmotic diuretic. It works by increasing the osmolarity of the blood, which then pulls fluid out of that swollen brain tissue and into the systemic circulation so it can be excreted.
And for non-pharmacological interventions?
The sequence is always airway. Airway patency is the unyielding priority. Then positioning. You maintain the head of bed, the HOB, elevated to 30 degrees to promote venous and CSF drainage.
Unless there's a specific contraindication.
Right. And this is where that HOB trap comes in. If a child is immediately post-VP shunt placement, the provider often orders an initial flat position
Why flat?
to prevent the CSF from draining too rapidly, which could cause its own complications like a subdural hematoma. So you always follow the specific post-op order, but generally 30 degrees is the rule for ICP management.
And fluid management must be tight.
Very strict. We require strict intake and output, I and O monitoring, and often restricted fluid volumes, because any kind of fluid overload will significantly worsen cerebral edema and, by extension, the ICP.
Okay, let's do a cluster quick recap.
The mechanism is that pediatric anatomic vulnerability, high water content, and those open fontanelles.
Hallmarks are a bulging fontanelle in an infant, forceful vomiting in a child, and the cushion triad in the late stage.
Red flags are those fixed and dilated pupils, a declining LOC, and any glucose-positive nasal discharge.
Priority actions: securing the airway, avoiding neck vein compression or hip flexion, and maintaining strict fluid balance.
And the big clinical trap is deprioritizing that LOC assessment or failing to recognize the cluster of symptoms that define the Cushing triad.
Our cluster introduction.
Yeah.
Our second cluster is all about seizure disorders and that critical endpoint, status epilepticus.
Right.
And the unifying concept here is the electrical firing mechanism. Everyone has a seizure threshold, but in children, that threshold is just naturally lower.
It is, and various stressors, especially fever, drop it even further, which just creates an environment that's ripe for crisis.
So when a child is febrile, what's happening?
That higher core temperature leads to massive neuronal excitability. And it's important to note the same physiological drop can happen in other high-risk groups, like pregnant women. For them, it's often linked to the potential for hypoglycemia, which is another factor that lowers that seizure threshold.
Okay, let's categorize the types. Identification is obviously paramount. We can start with generalized seizures, the ones involving both hemispheres.
And the most recognizable one is the tonic-clonic seizure. That's marked by a sudden loss of consciousness, stiffening, which is the tonic phase, and then the rhythmic jerking, which is the clonic phase.
But there's one that's frequently missed, right? Sometimes for months.
Yes, the absent seizure, or petit mal. These involve very brief, like seconds-long, staring spells, sometimes with a subtle, rapid blinking. The child loses awareness completely.
And they don't remember it.
No recollection of the event. They're often first noticed by teachers because the child just stops responding mid-sentence or mid-activity. It's a very subtle but critical diagnostic cue.
Then you have the focal or partial seizures, which are confined to one area of the brain.
Exactly. And these can be simple, meaning consciousness is maintained. So you'll see isolated symptoms like localized twitching or maybe a strange sensory experience, like an unusual taste or smell. That's often called an aura.
Or they can be complex.
Right. Complex is where consciousness is impaired. The person is left confused, dazed, or just unable to respond.
And it's important to remember that focal seizures aren't just electrical events, right? They could be pointing to something else.
Absolutely. They may point toward an underlying structural pathology. It could be a cyst, a tumor, or an abscess in that specific brain area. It always requires a full workup.
Okay, a very common pediatric presentation is the febrile seizure.
Yes. These happen between 3 months and 6 years of age, and they're in response to a rapid spike in temperature. While the recurrence risk is high, especially if the first one happens before age 1, the prognosis is overwhelmingly good after age 5. They very rarely cause long-term neurological damage.
The clinical urgency really increases dramatically when we talk about status epilepticus.
Oh, absolutely. This is defined as a seizure lasting over 30 minutes, or a series of seizures where the child doesn't regain consciousness in between.
And the risk here is huge.
The risk is permanent anoxic brain injury and death. It demands immediate intervention to secure oxygenation.
Okay, some high-yield facts for immediate crisis management. During an active seizure, you never try to restrain the child or put anything in their mouth.
Right. The infamous tongue glade is not just unhelpful, it's actively dangerous.
Positioning is key.
It is. The single most important immediate non-farm action is to position the child laterally, the recovery position. This helps facilitate the drainage of secretions and keeps the airway patent.
Okay, clinical reasoning and avoiding pitfalls. When a child presents seizing, the absolute priority is airway.
Always. You have to maintain a patent airway before you do anything else, before you address medications or specific focal signs, and at the same time, you must accurately time the seizure. The duration is what dictates your treatment protocols.
Let's discuss fever management, because preventing febrile seizures is a major point for parent education.
It is. The principle is to use acetaminophen to manage the fever aggressively. And we strictly counsel against using aspirin in any child with a viral illness like chickenpox or the flu because of that risk of Reye syndrome, which we'll get into more in the next cluster.
And what about things like cold baths?
That's another critical education trap. Using cold baths or alcohol sponging actually causes peripheral vasoconstriction and shivering. Those are the body's mechanisms to raise core temperature.
So it could make it worse.
It could potentially worsen the seizure risk. Promoting oral fluid intake is the appropriate non-pharmacological way to help cool them down.
Shifting to diagnostics,
Mhm.
those brief staring spells with impaired awareness, that's the classic picture of absent seizures.
It is. And a dietary detail that's often overlooked. The ketogenic diet, which is a high-fat, low-carb regimen sometimes used for refractory epilepsy,
Right.
it significantly increases the risk for kidney stones because of high uric acid levels.
Oh.
So flank or side pain in a child on this diet is a huge clinical red flag. Also remember that this diet alters their metabolism so significantly that it often makes routine lab results inaccurate.
Good to know. Let's talk pharm and non-pharm management. For emergency seizure termination, stopping the seizure itself, what are we using?
The go-to medications are benzodiazepines, specifically lorazepam atavon, which can be given IV or rectally. Phenytoin is often used as a loading dose to prevent a recurrence.
And for pregnant women.
Magnesium sulfate, that's the agent of choice for eclamptic seizures in pregnancy.
For chronic maintenance, therapeutic drug monitoring is key, especially in kids.
It is. Children grow so rapidly, and they can quickly outgrow their dosage. This means their therapeutic blood level drops, which significantly increases their risk of having another seizure.
We should probably highlight some specific drug administration rules.
Yes. Valproic acid, Bepicote, is notorious for GI irritation. It must be taken with food to minimize this. Giving it on an empty stomach is a definitive administration error that leads to vomiting and, noncompliance.
Okay.
We also have to monitor for vitamin D and folic acid deficiency with long-term use of anti-seizure meds like phenytoin, phenobarbital, and valproic acid.
And one final point. Phenytoin is often less effective in teenagers. That's a common challenge for compliance and management in that age group.
Right. Non-pharmacologically, it's all about that lateral positioning. And those dietary modifications, like the ketogenic diet, are therapeutic options, but you always have to be monitoring for that kidney stone complication.
Okay, a cluster quick recap.
The mechanism is a lowered seizure threshold from things like fever, hypoglycemia, or structural focal lesions.
Hallmarks are an aura, loss of consciousness and generalized seizures, or those subtle staring spells and absent seizures.
The single biggest red flag is a seizure lasting over 30 minutes. That's status epilepticus.
Priority actions are securing airway patency, lateral positioning, and accurately timing the seizure.
And the key clinical trap to avoid is inserting a tongue blade or giving valproic acid on an empty stomach.
All right, cluster introduction. Our third cluster is focusing on inflammation of the central nervous system. So we're talking CNS infections like meningitis and encephalitis, and then that unique autoimmune peripheral neuropathy, Guillain-Barré syndrome.
Yes. Yeah.
And the unifying thread here is that all of these conditions require swift diagnosis, often through a lumbar puncture, and really aggressive respiratory monitoring.
Right. It's because of the critical risks of either inflammatory swelling or an ascending paralysis that can compromise the child's ability to breathe.
Let's start with meningitis, the inflammation of the meninges.
It can be caused by viral, bacterial, or fungal pathogens. The hallmark symptoms in children are fever, an intense headache, photophobia, like sensitivity to light nausea and vomiting, and the classic sign of neutral rigidity or a stiff neck.
And sometimes in younger kids, the symptoms can look a little different.
They can almost mimic a psychiatric illness or just extreme, inconsolable irritability.
So the differentiation, which is what determines the treatment, requires a lumbar puncture, an LP, to analyze the CSF.
Right, and bacterial meningitis is the lethal enemy here, especially for infants.
So if it's bacterial, what are we seeing in that CSF?
The findings are very distinct. The fluid itself will look turbid or cloudy. You'll see significantly elevated white blood cells, specifically neutrophils. You'll see increased protein content and a high opening pressure.
But what's the definitive marker?
The definitive marker is a decreased glucose level. And it's important to know why. It's because the bacteria are actively consuming the glucose, basically starving the brain cells.
Wow.
And if the physician notes a release of pressure when they insert the needle, That is highly suggestive of an acute bacterial infection.
And on the other side, viral meningitis.
Viral meningitis presents with similar, but generally milder symptoms. The child seems sick, but not as sick as a child with a bacterial form. The CSF will usually show elevated lymphocytes, not neutrophils, and a normal glucose level.
Okay, moving to encephalitis, which is inflammation of the brain tissue itself.
Right. The symptoms overlap with meningitis malaise, apathy, fever, nausea, vomiting, but they can be accompanied by more overt signs of brain irritation, like hyperactivity or acute confusion.
Now, let's talk about Rey syndrome again. We touched on it earlier.
It's an acute encephalopathy. It's a severe, toxic inflammatory insult to both the brain and the liver. And the association with salicylate or aspirin used during recovery from viral illnesses, especially chickenpox or influenza A or B, is so strong that we just avoid aspirin in pediatrics.
What are the early signs we need to watch for?
The early signs are crucial. Severe, persistent nausea and vomiting, followed rapidly by confusion, lethargy, and progressive mental status changes, all due to cerebral edema. It demands immediate supportive care to manage that ICP.
And finally in this cluster, we have Guillain-Barré syndrome, GBS.
Which is the most common cause of acute flaccid paralysis in children, usually between ages 4 to 8. This is an autoimmune response. It's often triggered about 1 to 3 weeks after a GI or respiratory infection, and the immune system basically attacks the peripheral nerve myelin sheath.
And the hallmark of GBS is?
Ascending muscle paralysis. The weakness and tingling start in the lower extremities in the feet, causing gait issues or a limp, and then it moves upward.
And that upward progression is the critical risk factor.
It is. As the paralysis ascends, it compromises the intercostal muscles and the diaphragm, which leads directly to respiratory failure.
So the critical risks are respiratory compromise and then autonomic dysfunction affecting the bowel and bladder.
Exactly. These children frequently require mechanical ventilation. And a little high-yield note, vaccines are generally avoided or postponed during the acute phase of GBS.
Okay. Clinical reasoning and avoiding pitfalls. The rule of thumb for suspected meningitis is really based on risk, right?
Right. If you even suspect meningitis, you start both broad-spectrum antibiotics and antivirals immediately. You do not wait for the CSF culture or for a specific pathogen ID.
Why not?
Because delaying treatment for bacterial meningitis is lethal, and airway and oxygenation are always the absolute highest priority.
Let's talk about the lumbar puncture. What's the nurse's role?
It's procedural, but it's vital. The LP is done to analyze the CSF, not to reduce ICP or inject meds. The nurse's absolute priority is holding that child securely in the knee-to-chest position for a prolonged time to make sure the procedure is successful and safe.
Okay. Are there any red flags for a really severe systemic infection?
Yes. A hemorrhagic rash, or purpura, is highly suggestive of overwhelming sepsis. It's often associated with meningococemia, which is a life-threatening form of bacterial meningitis.
And a positioning detail. The opistotonic position where the head and neck are hyperextended.
Right. That's actually an instinctive action by the child. They do it to temporarily relieve the pain and discomfort from the increased meningeal irritation and ICP. It looks alarming, but we tolerate it temporarily.
The GBS priority is singular.
It is. Because of that risk of ascending paralysis, the immediate priority assessment is respiratory effort and depth of breathing. Any decline warrants immediate notification and preparation for intubation.
And a specific drug trap.
If a patient has botulism, which is a similar neuromuscular blockade, aminoglycoside antibiotics like gentamicin are contraindicated because they actually worsen the neuromuscular blockade.
Good to know. Pharm and non-pharm management for meningitis.
Pharmacologically, it's aggressive. Immediate antibiotics and antivirals until you confirm the causative agent. Non-pharm management includes droplet isolation precautions, which have to be maintained for 24 hours after antibiotics are started.
And comfort measures.
Yes, low light, quiet room, and positioning in semi-Fowlers. And here's the nursing trap. Measuring head circumference. This is only routine for children under 2 who still have open sutures.
For GBS, treatment often involves
Intravenous immunoglobulin, IVIG. It helps to modulate that autoimmune response. Non-pharm management is focused purely on respiratory support, which often includes complex ventilator care and careful monitoring of INO as their autonomic function can be compromised.
Okay, let's do a cluster quick recap.
The mechanism is inflammation of CNS structures, so the meninges or the brain, or of the peripheral nerves, like in GBS.
Hallmarks are neutral rigidity, photophobia, fever, and maybe some psych-like symptoms in meningitis. or that ascending weakness in GBS.
Red flags include low CSF glucose, a hemorrhagic rash, or a rapidly declining respiratory effort.
Priority actions are immediate initiation of antibiotics and antivirals, and a rigorous respiratory assessment in GBS.
And the clinical traps are waiting for culture results to treat, or using aspirin during a viral illness because of that Ray syndrome risk.
Okay, cluster introduction. We're now shifting from those acute crises to more chronic structural conditions. Hydrocephalus, spina bifida, and cerebral palsy.
Right.
The unifying concept here is that these are either non-progressive disorders or structural malformations that are going to require lifelong holistic management.
Exactly. We're focusing on maximizing mobility, ensuring proper elimination, promoting developmental milestones, and preemptively managing all those secondary complications like latex allergy or contractures.
Let's begin with hydrocephalus.
This is the result of an imbalance between CSF production and absorption. It leads to fluid accumulating in the ventricles and, consequently, increased ICP. This is often congenital, but it can also be acquired.
And the definitive treatment is the placement of a ventriculoperitoneal or VP shunt.
Correct. This device shunts the excess CSF from the ventricles down to the peritoneal cavity where it can be safely absorbed.
So management is meticulous.
Very. It's constant monitoring for signs of ICP and, crucially, regular, accurate measurements of the head circumference, which you have to plot against the child's growth curve.
And shunt complications are pretty common, right?
They are. They're common and recurrent. You can have infection, shunt failure, or the child just simply outgrows the device and needs a revision.
Is there a specific safety instruction for parents?
Yes, and it's a critical one that's often missed. It's about magnets. They have to keep tablets and magnetic toys at least 2.5 centimeters away from the shunt valve site.
Why is that?
Because magnetic interference can accidentally alter the valve pressure setting, causing it to malfunction.
Okay, that brings us to a clinical trap alert. Post-op positioning.
Yes. After a VP shunt placement, a nurse must question in order to significantly elevate the head of bed. To prevent the CSF from draining too quickly, which can lead to the ventricles collapsing, or a subdural hematoma, the infant is typically kept flat initially.
As per the specific provider order.
Always.
Yeah.
And we also monitor closely for abdominal distension, which could signal complications like peritonitis or an ileus at the shunt's endpoint.
Okay, moving to myelodysplasia, or spina bifida, specifically the most severe form, meningomyelocele.
This is a malformation where the spinal cord and the canal fail to close completely, and the etiology is very strongly linked to the mother's nutritional status.
And the prevention is incredibly high yield.
It is. It requires adequate maternal folic acid and B12 intake. All women of childbearing age should take 0.4 milligram a day of folic acid. But if there's a prior history of a neural tube defect, an NTD, that dose needs to be increased significantly, often up to 4 milligram a day.
And the clinical impairments are pretty predictable based on where the defect is.
They are. You'll see impaired physical mobility from neuromuscular paralysis below the lesion and impaired urinary and bowel elimination because of sensory and motor nerve deficits.
So management is key for independence.
Right. Regular, clean, intermittent catheterization, or CIC, and specific bowel training are absolutely fundamental to their independence.
There's a high-yield secondary risk here that's pretty alarming.
Yes, the frequency of latex allergy, and you have to understand why. These children are subjected to dozens, sometimes hundreds, of surgical procedures and repeated catheterizations right from birth.
So it's massive, repeated exposure.
Exactly. And that repeated exposure sensitizes them to latex rubber products.
And this latex allergy risk can extend to other things, right?
It does. It extends to cross-reactive food allergies, which you have to screen for. Specifically foods from the rubber tree family like banana, avocado, papaya, and kiwi.
What's another risk for these patients?
Another grave risk, especially for upper-level defects, is the potential for Chiari type 2 malformation. This is where the brainstem and cerebellum prolapse down into the spinal canal.
And that can cause?
It can cause hydrocephalus and, critically, apnea or snoring spells, which require immediate investigation.
Okay. For preoperative care of a newborn with an open meningomyelocele sac, what are the priorities?
Protection and positioning. You do not apply a diaper because it could irritate or contaminate the sac. The newborn must be positioned in the prone position or side lying to prevent any pressure on the sac and potential CSF leakage.
And we should stress that these children typically have normal intelligence.
Absolutely.
Yeah.
So management focuses heavily on promoting independence high-fiber diets, frequent position shifts to prevent pressure injuries, and mastering self-catheterization.
Our third condition is cerebral palsy, CP.
This is a permanent, non-progressive disorder of movement and posture. It results from a brain injury that happens pre, peri, or postnatally, usually before age 5.
And it used to be blamed on birth anoxia.
It was, but we now understand that prenatal abnormalities, premature birth, and stroke in low birth weight infants are actually more common causes.
The early warning signs are key for getting early intervention services.
They are. You look for poor head control beyond the expected age, a failure to smile by 3 months, generalized developmental delays, and specifically hypertonia.
That's stiff, rigid limbs.
Yes, and it often causes the child's legs to cross when they're carried or standing. That's the classic scissoring legs. Persistent primitive reflexes are also a major cue.
CP management is multidisciplinary.
It has to be. Pharmacologically, baclofen is the primary agent used to reduce spasticity, and it's often delivered continuously through an epidural pump. We also use botulinum toxin, or Botox, for specific localized hyperspasms.
And there's a trap with baclofen.
There is. The major side effect is dose-dependent hypotonia, or excessive muscle relaxation. You have to monitor closely for signs that the child is too relaxed or struggling with necessary motor functions. That signals a dangerous level of medication.
And non-pharm management.
It involves intensive OT, PT, and speech therapy, along with specific positioning to prevent painful and debilitating contractures.
All right, let's do a cluster quick recap.
The mechanism involves a structural malformation, like in spina bifida, a CSF imbalance, like in hydrocephalus, or a non-progressive brain injury, like in CP.
Hallmarks are an increased head circumference for hydrocephalus, paralysis, and a high latex allergy risk for spina bifida, and poor head control or scissoring legs for CP.
Red flags include any signs of shunt failure or infection, apnea spells, which can be related to Chiari II and SB, and excessive hypotonia after baclofen administration.
Priority actions are prone or side-lying positioning for the spina bifida sac, rigorous latex precautions, and monitoring head circumference.
And the clinical traps include elevating the HOB immediately post-shunt or prescribing a low-fiber diet in spina bifida patients.
Okay, cluster introduction. Our final essential cluster covers the vast landscape of cognitive function, genetic syndromes, and mental health alterations.
It's a big one.
It is. The unifying idea here is that these conditions impact adaptive behavior, intellectual functioning, or learning pathways, and they all require customized behavioral interventions, supportive environments, and targeted developmental screening.
Let's start with intellectual disability, ID. Clinically, this is defined by an IQ score less than 75, coupled with significant limitations in adaptive behavior, so conceptual, social, and practical skills, all observed before age 18.
And the causes are wide-ranging.
Very. Prenatal errors like congenital rubella or syphilis, exposure to teratogens like alcohol, which leads to fetal alcohol syndrome, trauma, or even severe malnutrition.
So prevention is really focused on prenatal health.
Exactly. Rubella immunization, strict education about alcohol and heavy metal exposure like lead or mercury.
For ID interventions, what's the paramount concern?
Safety. Children with ID may not recognize common hazards, so the environment and their toy selection have to be rigorously assessed for safety.
And the clinical focus?
It's on providing emotional support involving the family in the Individualized Education Program, the IEP, and promoting self-care. The clinical trap is assuming that a low intellectual potential means dependency. We actively promote independence in ADLs and avoid recommending institutionalization.
Okay, now for the key genetic syndromes associated with ID. Let's start with Down syndrome, or trisomy 21.
It's the most common genetic cause of ID. The hallmark features include generalized hypotonia, or fluffiness, a flat nasal bridge, a single transverse palmar crease, and a protruding tongue.
And management really focuses heavily on the associated comorbidities.
It has to. Fully 40 to 50% of these children have congenital heart defects. They also have a dramatically increased risk for leukemia, thyroid disease, and importantly, atlantoaxial instability,
Which is
a weakness in the joint between the first two cervical vertebrae. This requires close monitoring, especially if they participate in contact sports because of the risk of spinal cord compression.
So annual screenings are mandatory?
Yes. Thyroid function, hemoglobin, and hearing tests. And here's a critical practical tip for feeding these infants. Because of the tongue thrusting reflex and that protruding tongue, you want to use a small, long, straight-handled spoon to push food gently to the back and side of the mouth to help them swallow.
Okay. The second most common is Fragile X syndrome, FXS.
It's an X-linked dominant disorder that primarily affects males. The features include a long face, a prominent jaw, large ears, and often large testicles or macroorchidism in males. Frequent otitis media is also a recurring problem.
And then Fetal Alcohol Syndrome, FAS.
Right, resulting from prenatal alcohol exposure. It has very specific craniofacial features. Clinically, we look for a long philtrum that groove between the nose and the upper lip, a very narrow upper lip, a flat midface, and a low nasal bridge. These features help differentiate FAS from other syndromes.
Okay, moving on to learning disabilities, which affect processing pathways.
Right. This includes dyslexia for reading, spelling, and writing, dyscalculia for math, dysgraphia for writing and composition, and dyspraxia, which is a motor planning issue that affects manual dexterity and coordination, making simple tasks like tying shoes really difficult.
Shifting to mental health, let's address autism spectrum disorder, ASD.
This is defined by developmental delays in social communication and language, and the presence of restricted, repetitive behaviors like arm flapping, spinning, or rigid, ritualistic behavior. These children often strongly resist physical touch and avoid eye contact.
So the management priority for ASD is creating predictability and safety.
Absolutely. You have to maintain a strictly structured routine and actively minimize environmental stimulation to prevent sensory overload. In the hospital, this means assigning a single bed, quiet room away from the nurse's station.
And behavior modification.
It's appropriate, especially focusing on reward systems for desired social behaviors.
Lastly, ADHD attention deficit hyperactivity disorder.
This is characterized by chronic impulsivity, inattention, and frequently sleep disturbances. And we know that prenatal smoke exposure is a risk factor.
Management for ADHD centers on environmental structure.
It does. Homework must be done in a quiet, low-distraction environment. TV watching is a common trap. Consistent routines help. In the classroom, seating the child at the front, not the back, helps with attention by reducing visual distraction. Promoting self-esteem by focusing on their strengths is also vital.
One final high-yield point on mental health screening.
Yes. School phobia and separation anxiety in children rarely present as just pure anxiety. They frequently manifest as recurrent somatic complaints.
Like stomach aches.
Exactly. Stomach aches, nausea, or headaches that happen specifically on school days but then resolve completely in the evenings or on weekends.
Okay, let's do a final cluster quick recap.
The mechanism involves a genetic error like in Downs or Fragile X, teratogen exposure like in FAS, or neurodevelopmental pathway differences like in ASD and ADHD.
Hallmarks are hypotonia and a palmar crease in Down syndrome, arm flapping and ritualism in ASD, or impulsivity and inattention in ADHD.
Red flags include a failure to make eye contact or resisting touch in ASD, or those school day somatic complaints pointing to a phobia.
Priority actions are developmental screening as the very first step, safety management, and maintaining a structured routine.
And the clinical traps are assuming low intellectual potential or exposing children with ASD to high sensory stimulation. Hashtag final global recap. So we've synthesized 5 complex pillars of pediatric neurology, and across all 5, I think the message is pretty consistent. Airway and oxygenation are always the primary concerns.
Right, whether it's due to acute swelling from an infection or trauma, or that ascending paralysis in GBS.
Exactly. And the clinical differentiation between acute and chronic and between an infant versus a child is really what separates safe practice from error.
And the most sensitive early indicators of neurological trouble are often the really subtle ones. A change in LOC and ICP, simple staring spells and absence seizures, or that sudden muscle relaxation that signals baclofen toxicity.
And prevention is paramount. Folic acid for structural defects, and rigorous environmental management like latex precautions or low stimulation for chronic conditions. Your attention to context, age, history, medication side effects, that's your ultimate defense against pitfalls.
We've seen that the anatomical and physiological differences in children just require a completely unique clinical approach. From understanding the mechanisms of the Cushing triad to knowing why a high-fiber diet is so essential in spina bifida.
It all connects.
It does. Which leaves us with a final provocative thought for you to consider. Early intervention is proven to fundamentally reshape developmental and long-term outcomes for children with structural and cognitive deficits.
It's so important.
So if we view these early services not as optional support, but as a critical form of preventative medicine, What societal and clinical resource allocation must health systems prioritize to ensure every infant flagged as high risk receives these life-changing interventions as early and as consistently as humanly possible?
That is a challenge for all of us in healthcare to address.